Chapter 27: Anger, Aggression, and Violence. Our objectives for this module are going to be to define anger, aggression, and violence, as well as identify any biological and cognitive risk factors for increased anger, aggression, or violent feelings and behaviors. Anger is an emotional response to frustration of desires, a threat to one's own emotional or physical needs, or a challenge. Aggression is an action or behavior that results in verbal or physical attack. Aggression tends to be used synonymously with violence. However, aggression is not always inappropriate and is sometimes necessary for self-preservation. On the other hand, violence is always an objectionable act that involves intentional use of force that results in or has the potential to result in injury to another person. In our first case study, your new patient, Mr. Otis, is assigned to your unit after getting into a fight outside a family restaurant. He got into an argument with the family, saying they threatened him. But witnesses weren't able to attest that the family had in fact said nothing to him at all, and had, until he approached them in anger, barely noticed him in the parking lot. Mr. Otis is a veteran with a history of post-traumatic stress disorder and comorbidities of depression and intermittent psychotic episodes. He does not appear to have a substance abuse disorder. In the hospital, violence is most frequently seen in emergency departments, psychiatric units, geriatric units, and intensive care units. It's likely that you'll need to manage violent behavior at some point in your career. Nurses are frequently targets of violence because they have the most direct patient contact. Violence can occur anywhere in the hospital, but it is most frequent in the emergency rooms, psychiatric units, geriatric units, and ICUs. And they're also overrepresented in patient and patient significant other attacks. Unfortunately, there's probably not going to be a hospital unit in the hospital that you are not in danger of having some sort of violent altercation. It is a sad fact that unfortunately you are dealing with people who are in very difficult and stressful times where emotions are burning very high. You're also dealing with a lot of patients who are very confused, very scared. And unfortunately, when you get in those situations, the risk for violence does increase. Other comorbidities include PTSD, substance use disorders, the coexistence with bipolar disorder. Anger and hostility are risk factors for chronic illness and may be predictive of hospitalizations for multiple chronic illnesses, everything such as hypertension and cardiovascular disease. They also have higher prevalence of inflammation in chronically ill older adults. Other risk factors could be a genetic predisposition, neurobiological issues such as brain injury or abnormalities, and other neurotransmitter imbalances. There could also be other cognitive factors, such as behavioral therapy and learned responses, and that social learning theory where they imitate others, where people coming from more violent backgrounds who have seen more violence or grew up around more violent household will be more predisposed to violence. Early behaviorists believe that emotions, including anger, were learned responses to environmental stimuli. The stimulus is often a perceived threat, and this perception leads to the emotional and physiological arousal necessary to act. Although the threat is usually understood as an alert to physical danger, Beck in 1976 noted that other threats to areas such as values, beliefs, and moral code could also lead to anger. Social learning researchers demonstrated that children learn aggression by observing and imitating the behavior of others, especially if that behavior is rewarded. Thus, children who watch television violence or experience violence in the home learn aggressive ways of resolving their problems. Let's begin with the application of the nursing process. Our objectives for this this module will be to discuss three types of assessment questions and their value in the nursing process. We also want to compare and contrast interventions for a patient with healthy coping skills with those for a patient with marginal coping skills, and also apply at least 4 principles of de-escalation with a moderately angry patient. We also want to be able to describe 2 criteria that make the use of seclusion and restraint more appropriate than verbal intervention. Role play with classmates about understandable but unhelpful responses to anger and aggression in patients, and also discuss helpful responses to anger and aggression within patients. Through assessment, we'll begin with our normal general assessment. From there, we'll also incorporate aspects such as trauma-informed care, as well as the patient's own self-assessment. Trauma-informed care is an older concept of providing care that has recently been reintroduced. It's based on the notion that disruptive patients often have histories that include violence and victimization. These traumatic histories can impede patients' ability to self-soothe and result in negative coping skills and create a vulnerability to coercive interventions, such as restraints by the staff. Continuing with our case study, in the unit, Mr. Otis's paranoia continues, and he becomes agitated and threatens to assault another staff person. He tells you, "You're the only one I think I can trust, but can I? Are you going to take their side?" It's a little manipulative there, too. What should be your best initial intervention for Mr. Otis at this point? A. Say if you do not calm down, seclusion will be needed. B. Address him with simple directions in a calming voice. C. Help him focus by rubbing his shoulders. Or D. Offer him a dose of antipsychotic medication. And obviously your answer here is going to be B. Address him with simple directions in a calming voice. A calming voice and simple non-emotional directions can help de-escalate the patient's anxiety. This is an initial intervention, so do not threaten him with seclusion or resort to antipsychotics. Rubbing his shoulders is inappropriate and may contribute to anxiety, not calm. A new nurse asks a coworker which patients are most likely to become angry or aggressive. What are some risk factors that may predict violent behavior? First is going to be a history of violence. That's the single best indicator of future violence. Also, patients who are delusional, hyperactive, impulsive, or predisposed to irritability are at higher risk for violence. Other major factors associated can be assessed with these questions. Does the patient have a wish or intent to harm? Does the patient have a plan? Does the patient have means available to carry out the plan? Does the patient have demographic risk factors such as male, age 14 to 24, low socioeconomic status, inadequate support systems, or prison time? Aggressive patients can occur most often in the context of limits setting by the nurse. History of limited coping skills, including lack of assertiveness or use of intimidation, indicates a higher risk for using violence. And like patients, nurses have their own histories. The nurse's ability to intervene effectively depends on self-awareness of strengths, needs, concerns, and vulnerabilities. Without this awareness, nursing interventions can end up being impulsive or emotionally based responses. Now, that self-awareness includes recognizing a choice of words and a tone of voice, as well as nonverbal communication through body posture and facial expression. You don't want to match his aggression with aggression, but you also don't want to be kind and too pushover. It's that professional, neutral demeanor. There are many nursing diagnoses we could consider here. Risk for violence, risk for suicide, difficulty coping, stress overload, or impaired impulse control. For the nursing process, we want to identify outcomes, planning, implement general interventions, health teaching and health promotion, and really depend on teamwork and safety, including the use of seclusion and restraints as a last resort in the case of that patient is a danger to themselves or others. There are 6 basic considerations for ensuring safety. Avoid wearing dangling earrings, necklaces, and scarves in an acute care environment. The patient may become focused on these and grab them, causing serious injury. Also ensure that there's enough staff for backup. Only one person should talk to the patient, but staff need to maintain an unobtrusive presence in case that situation escalates. Always know the layout of the area. Correct placement of furniture and elimination of obstacles or hazards are important to prevent injury if the patient requires physical interventions. Do not stand directly in front of the patient or in front of the doorway. The patient may consider this position as confrontational. It's better to stand off to the side and encourage the patient to have a seat. If a patient's behavior begins to escalate, provide feedback. You seem to be very upset. Such an observation allows exploration of the patient's feelings and may lead to de-escalation of the situation. Avoid confrontation with the patient, either through verbal means or through a show of support with security guards. Verbal confrontation and discussion of the incident must occur when the patient is calm. A show of force by security guards may serve to escalate the patient's behavior. Security personnel are better kept in the background until they're needed to assist. Mr. Otis becomes increasingly agitated, and when you come back from break, you find out he wants to talk to you alone. Your best response is to A. Respect his privacy and see him alone. B. Do not speak to him in private. It's time for the team to confront him calmly as a group. C. Ask him to be put in restraints first, or take security staff with you. Or D. Go speak to him in a non-confrontational way and ensure that there are other staff nearby for backup. And that answer here is D. You want to ensure that there is enough staff for backup. Only one person should talk to the patient, because he does have a right to privacy. but staff need to maintain an unobtrusive presence in case the situation escalates. Avoid confrontation with the patient, either through verbal means or through a show of force with security guards. Verbal confrontation and discussion of the incident must occur when the patient is calm. A show of force by security guards may serve to escalate the patient's behavior. Therefore, security personnel are better kept in the background until they're needed to assist. Seclusion and restraint. Just as they sound, seclusion is the involuntary confinement of a patient alone in a room or in an area from which the patient is physically prevented from leaving. Whereas restraints are any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, body, or heads freely. The goal of seclusion is never punitive. Rather, the goal of seclusion is safety of the patient and others. Seclusion is less restrictive than restraint and may be helpful in reducing sensory overload. There are several contraindications for the use of seclusion and restraint. Patients who have extremely unstable medical and psychiatric conditions are not considered safe candidates for these treatments. Chronic obstructive pulmonary disease, spinal injury, seizure disorders, and pregnancy are examples of other contraindicated problems. Delirium and dementia may make seclusion and restraint intolerable due to the absence of stimulation. These restrictive measures should be avoided in patients who are overtly suicidal and those who require monitoring for severe drug reactions or overdoses. The guidelines for the use of mechanical restraints include the indication for use. Are they absolutely necessary, and are they a danger to themselves and others? The legal requirements are going to be set by state laws and differ slightly state by state, but they're all going to include a need for careful documentation, clinical assessments, observation, a timeline, and an idea for release, as well as restraint tips, making sure you're checking that. Is it only 2 fingers tight? Are we watching this patient closely? It's indication for a 1-to-1 at many hospitals that they have 1-to-1 observation because there is a danger of them fighting against those restraints left alone for too long. Continuing with our case study, Mr. Otis becomes violent and must be placed in restraints. What questions need to be asked after this incident? First would be, could we have done anything that could have prevented this episode? If yes, then what could have been done, and why was it not done in this situation? Did the team respond as a team? Were team members acting according to the policies and procedures of the unit? If not, why not? How do staff members feel about this patient, about this situation? Feelings of fear and anger are discussed and handled. Employee morale, productivity, the use of sick leave time, transfer requests, and absenteeism are all affected by patient violence. Especially if a staff member has been injured, staff members must feel supported by their peers as well as the organizational policies and procedures. It can be very difficult on everyone involved if you're working in an area with lots of patient violence. Also consider, is there a need for additional staff education regarding how to respond to violent incidences? How did the actual restraining process go? What could have been done differently? To not only focus on whether the staff was acting like a team. And if an injury occurred, has it been reported and cared for? An often overlooked form of restraint is medication themselves. Medication is a form of restraint. Also with anger, aggression, and violence in the general hospital setting, keep in mind to have patients with healthy coping skills who are overwhelmed, patients with marginal coping skills, and patients with cognitive deficits. Finally, Mr. Otis is restrained. As his nurse, what is your first priority? Is that A, debrief the patient, B, ensure the patient's safety, C, administer a sedating medication, or D, obtain an order from the healthcare provider? And that answer, as always, is going to be B, ensuring the patient's safety. Once in restraint, a patient must be directly observed and formally assessed at frequent, regular intervals for level of consciousness, level of activity, safety within the restraints, hydration, toileting needs, nutrition, and comfort. And for our final question, which patient behavior is a criterion for mechanical restraint? Would that be A, screaming profanities, B, assaulting staff, C, refusing a medication dose, or D, throwing a pillow at another patient? And that answer is going to be B, assaulting a staff person. These restraints is only used in the case when the patient is a danger to themselves or others. This is not something punitive we do. This is something we do for both the safety of both the patient and the staff. Especially if you're working in mental health and a lot of other areas within nursing. You may have to deal with aggressive patients, and it's going to take some practice. It can be difficult. But at the same time, you're going to get a lot more experience, and you're going to be able to handle them much more effectively after you've worked in that area for a little while. Anyway, that's all we got in this chapter. I'll see you in the next slides.